Good afternoon and happy viewing, everyone. I'm Dr. Michael Reinhardt, Director of the Brooklyn Initiative to Develop Geriatrics Education, or BRIDGE for short. And it's my pleasure to welcome you today for this session on dementia, a cardiovascular disorder in late life, an important question and topic that affects the care and quality of life for many of our older patients. This lecture is one of a series brought to you in support of the activities of the BRIDGE program, as well as our new advanced certificate program in public health geriatrics in our School of Public Health. This talk will also be used to create an online learning module for continuing education for all of Brooklyn's providers, students, and trainees. The Brooklyn Initiative to Develop Geriatrics Education is funded by the Health Resources and Services Administration as part of their Geriatric Workforce Enhancement Program. The BRIDGE program was developed in partnership between 4 of the colleges and schools at SUNY Downstate Health Sciences University, including the College of Medicine, College of Nursing, School of Public Health, and the School of Health Professions. This interprofessional partnership of our colleges and schools is complemented by outstanding partners in the community, including the New York City Health and Hospitals, Kings County, Brownsville Multi-Service Family Health Center, and the Fort Greene Council and its network of 13 senior centers throughout Brooklyn. The overall goal of the BRIDGE program is to provide the education and support needed for Brooklyn to become an age and dementia-friendly place for our senior neighbors to obtain their health care. And it is our pleasure today to welcome Dr. Jason Lazar to speak on this important topic. Dr. Lazar is Vice Dean of Education in the College of Medicine at SUNY Downstate Health Sciences University, Chair of the Department of Medical Education, Director of Non-Invasive Cardiology, and the former Director of the Cardiology Fellowship Training Program at SUNY Downstate. He is a distinguished teaching professor of SUNY, as well as Professor of Medicine, Neurology, Public Health, Molecular and Cell Biology. Dr. Lazar received his medical degree from the SUNY Upstate Medical Center at Syracuse and completed his postgraduate training at the University of Pittsburgh Medical Center in Pennsylvania. He received his MPH from the Columbia University School of Public Health. His research interests include brain-heart interactions, arterial stiffness, the epidemiology of coronary heart disease in women and in high-risk populations, and in health disparities. He is a member of the editorial board of multiple journals and serves as a reviewer for numerous peer-reviewed journals. He is widely published with more than 200 peer-reviewed manuscripts and has embarked upon several international collaborations, including medical missions to various countries. He is a fellow of the American College of Physicians, the American College of Cardiology, the American Heart Association, and the American College of Chest Physicians. He has previously served as the chair of Cardiovascular Network and New York State representative of the Governor's Council of the American College of Chest Physicians and on the American Society of Echocardiography Research Committee. He has received multiple accolades for academia, including the SUNY Chancellor's Award for Excellence in Scholarship and Creative Activities. He currently serves as the co-principal investigator of a multi-center R01 grant investigating mechanism of left ventricular dysfunction and HIV infection. Over the past decade, Dr. Lazar has been awarded 4 different New York State Department of Health Empire Clinical Research Investigator Program training grants, and now serves as SUNY Downstate's ECRIP Committee Chair and liaison to the Department of Health. Thank you, Dr. Lazar, and we hope you enjoy this important talk today.
Good afternoon. I'm Jason Lazar, and it's a pleasure to present on the topic of cardiovascular disorders in late life. I'm grateful to be part of the Brooklyn Initiative to Develop Geriatrics Education, the HRSA Geriatrics Workforce Enhancement Program. I don't have financial disclosures. My only disclosure is that I am not a neurologist. Let's start off with a case. A 76-year-old woman presents, and she's been widowed for 12 years, has a history of hypertension for 25 years, and is treated with a combo pill of valsartan and hydrochlorothiazide. She began some unintentional weight loss 5 years ago and progressive memory loss for perhaps 3 years. Her daughter reports that she neglected to pay her property taxes for the past 2 years, an important social history. Blood pressure was 132/64, pulse 76 and regular. Her physical exam was otherwise normal. On EKG, she had sinus rhythm, some left axis deviation, and nonspecific ST segment and T wave changes. Her labs were unremarkable. Notably, she had normal thyroid function tests with a normal TSH, and her LDL was 134 milligrams per deciliter. So how should this patient be treated? She obviously has dementia, a common condition, especially late in life, characterized by memory impairment, as well as impairment in other cognitive domains. Dementia is almost universally progressive, associated with impairment in functional status, and is associated with considerable morbidity and mortality. Moreover, it's progressive without cure. So, the topic of today's talk is dementia, a cardiovascular disorder in late life? The objectives of today's discussion will be to make the case that dementia should be considered a vascular disease, irrespective of the type, to understand which cardiovascular risk factors contribute to dementia, and the temporal relationship that exists between risk factor appearance and cognitive dysfunction, and to identify potential opportunities for delaying the onset or slowing the progression of cognitive dysfunction. There are various types of dementia, and I make my disclosure again, I am not a neurologist. There's Alzheimer's disease, which accounts for 60% of all cases. Vascular dementia, another 20%. And this is the most common form of dementia in Asia. It usually is observed in a stepwise progression with focal cognitive deficits or impaired executive function, but memory impairment is not necessarily the case. And furthermore, vascular dementia is expected to be the most commonest form throughout the world in years to come. There's a mixed type of dementia. There's Lewy body dementia, which comprises 10% of all cases, and 10%, and this is commonly associated with Parkinson's syndromes, and others as well, comprising another 10%, including frontal lobe dementia, which involves executive dysfunction, poor planning, and impaired judgment. Recent memory is actually usually preserved. There's abulia, disinhibition, sometimes depression, and other forms in this miscellaneous group, including alcohol and corticobasilar. Alzheimer's disease occurs on a progression, as do all forms of dementia. And it's important to differentiate this from the mild degree of cognitive impairment that's seen in normal aging. This gives us a large window of opportunity to try to intervene and to prevent the more rapidly progressive cognitive impairment seen as a prodrome to overt dementia. And we're all aware of the rising rates of dementia, notably Alzheimer's in the United States. Currently, there are almost 6 million persons with Alzheimer's dementia, and this is roughly 2/3 of the total cases. And after age 65, the risk doubles nearly every 5 years. After age 85, the risk is nearly 1 in 3. And Alzheimer's disease, the most common form of dementia, is universally viewed as a neurodegenerative disorder. It involves amyloid and tau deposition. Regarding amyloid, beta amyloid is a type of glycoprotein that is abnormally concentrated in the brains of patients with Alzheimer's disease. Amyloid aggregates into clumps known as plaques, which are supposedly toxic. They cause inflammation, oxidation, and injury to brain cells that is irreversible. Secretases and presenilins are enzymes that are involved in producing beta amyloid, and it's unclear whether beta amyloid is a cause or a bystander. With regard to tau, this is a protein that forms microtubules which transport nutrients into cells. And when these tau proteins get hyperphosphorylated, they become neurofibrillary tangles, which go on to further damage cells. So we've learned a lot about the neuropathology of Alzheimer's disease since Alzheimer himself described the first case of a 57-year-old man back in 1907. Well, when you look at comorbid conditions that accompany Alzheimer's disease, the most common happen to be hypertension, osteoarthritis, depression, diabetes, coronary, and cerebrovascular. It's remarkable that 4 out of the 6 are related to vascular disease. Other studies from Europe have also shown that cardiovascular-related conditions are the most frequent comorbidities in patients with dementia. And furthermore, when they are synergistic with other conditions such as chronic pain, depression, hearing loss, constipation, or diabetes, in terms of increasing a person's risk for eventually developing dementia. And when you look at the various risk factors, there's some good news and not so good news. In this study of 215 subjects without cognitive impairment, mean age 62 years, who were cognitively intact, both amyloid and tau deposition were associated with total cholesterol, LDL cholesterol, systolic blood pressure, pulse pressure, and the Framingham risk score for cardiovascular events. This was true in patients not on medications, but medications seem to disrupt these associations, giving us hope for an opportunity to prevent this progressive deteriorative disease. A couple words about vascular dementia. From a historical perspective, in 1910, Kraepelin concluded that arteriosclerotic insanity was the most frequent form of senile dementia. Since then, there's been multiple names, including multi-infarct dementia, ischemic vascular dementia, arteriosclerotic dementia, cerebrovascular dementia, and even ischemic vascular dementia. There are variable diagnostic criteria, but in general, vascular dementia is associated with a stepwise progression, with prolonged plateaus or fluctuating courses, and there are focal cognitive deficits that may not necessarily involve memory impairment. There's often impaired executive function, that of problem solving or even judgment, and the diagnosis of vascular dementia is strengthened by imaging studies showing ischemia or the history of cardiovascular risk factors or atherosclerosis in other vascular territories such as the coronary arteries or peripheral arterial disease. Vascular dementia can be categorized into several categories. Large vessel vascular dementia is temporally related to stroke, and there's usually concomitant depression. Small vessel vascular dementia involves frontal lobe defects, executive dysfunction, inattention, depression, abnormal gait, sometimes Parkinson's syndromes, and once again, memory impairment may be less pronounced. Then there's ischemic hypoxic vascular dementia and hemorrhagic dementia as well. Irrespective of the exact cause, vascular dementia may be viewed as a cascade of events with vascular risk factors resulting in cerebral vasculature damage of multiple distinct pathologies, large vessel, small vessel, hemorrhage, or hypoperfusion, and these create a final common pathway to vascular dementia with damage to critical cortical and subcortical structures and interruptions in the circuitry of the brain. To balance out the discussion, because cardiovascular disease increases with age, it's been suggested that cognitive decline seen in patients with progressive dementia may lead to worsening self-care and a greater risk of cardiovascular disease. This is in one study, patients with dementia were found to be at greater risk of cerebrovascular disease rather than cerebrovascular disease, conferring a greater risk for dementia. And this is a very fertile area for investigation at present. Nonetheless, I hope that I've made a compelling argument that dementia is indeed a vascular disease, as the majority of patients with Alzheimer's disease, a disorder that is traditionally viewed as neurodegenerative, has a vascular etiology. In fact, 80% of all Alzheimer's disease patients' brains have evidence of significant vascular pathology. And I wonder if the 20% that don't really do, we just haven't looked for it in the proper ways. Evidence for impaired cerebrovascular reactivity, even in preclinical Alzheimer's disease. And moreover, cardiovascular risk factors are prevalent in patients prior to dementia and in those with neurodegeneration prior to clinical manifestations. Well, in summary, for all types of dementia, classic risk factors vary depending upon their timing. During midlife, hearing loss, hypertension, obesity, emotional trauma, head trauma, ApoE, hearing loss, and lower educational status, perhaps because of less cognitive reserve, are predictive of late life dementia. And later in life, the presence of cerebrovascular disease, smoking, depression, reduced physical activity, social isolation, and diabetes become more paramount. Therefore, hypertension and obesity and ApoE gene status are predictive in midlife, whereas diabetes and cerebrovascular disease and smoking are more predictive when they occur as exposures in late life. In fact, in a fairly well-validated midlife dementia risk score, you can see that elevated systolic blood pressure and a BMI, low physical activity, and again, this ApoE4 positive status are highly predictive of subsequent late life development of dementia. Therefore, dementia in advanced age could be viewed as both a neurodegenerative and a vascular disorder, with both mechanisms being synergistic. But how do common illnesses contribute to dementia? Diabetes, high blood pressure, obesity, and in the cardiovascular literature, congestive heart failure, and even atrial fibrillation and coronary disease, the big three. Well, it's hypothesized that oxidative cell damage, insulin resistance, fat cell activity, all create inflammatory stroke-like damage, which eventually goes on to result in dementia. Moreover, risk factors may be synergistic, as it was found that a cumulative number of vascular risk factors was associated with an increase in brain amyloid deposition, and also the greater the number of risk factors, the earlier the onset of dementia. But what about the specific risk factors? Well, we talked before about their occurrence at different times of a person's life. We differentiated midlife versus late life onset and spoke about how hypertension and obesity were midlife cardiovascular risk factors, whereas diabetes and cerebrovascular disease were more predictive in late life. Well, as it turns out, when we're dealing with patients in late life, they've had cumulative exposures to the various cardiovascular risk factors. So it's important to look at trajectories of the various risk factors. This is a slide showing blood pressure trajectories from midlife to late life in women who did and did not develop dementia who were followed for over a 37-year period. The dashed line is dementia cases, whereas the filled-in line is non-dementia cases. And as you can see, their blood pressure rises more rapidly in the dementia group, but then falls more precipitously in the dementia group as compared to the non-dementia cases. Therefore, it appears as though the blood pressure trajectory is novel to that of dementia, in that while all subjects have a rise and then an eventual fall in blood pressure during aging, these changes are more marked in patients with dementia. So what happens in blood pressure and dementia? Numerous papers have shown that blood pressure rises decades before cognitive dysfunction, and blood pressure elevation may promote the development and the progression of amyloid and tau neuropathology. Patients with dementia exhibit a greater longitudinal blood pressure decline, as well as a steeper rise in midlife. Low blood pressure late in life in patients on medications is actually highly predictive of dementia 2 years later. Specifically, steeper reductions in diastolic blood pressure over 20 years was found related to greater cortical atrophy. And moreover, low diastolic blood pressure was found related to smaller hippocampal and amygdala volumes. So there's an emerging literature to show that changes in blood pressure along a patient's age trajectory may be important indicators and potentially impact upon the course of dementia. Now, this drop in blood pressure in late life is actually a very interesting phenomenon. It is associated with greater all-cause mortality and greater frailty as well. And when you look at other trajectories of cardiovascular risk factors, such as obesity, they actually demonstrate a very similar pattern. Shown above is the trajectory of body mass index over 28 years in the Whitehall 2 study. And look, the dementia group shown in red has a greater rate of rise, ranging from 28 to 12 years before the onset of clinical dementia. And then the patients who eventually go on to develop dementia have a more rapid decline in body mass index. So, in summary, their blood pressure rises more quickly and then falls more precipitously, and so does their BMI. There's a greater rate of rise and a greater decline. What about cholesterol? Well, it turns out that hypolipidemia is associated with dementia. Dementia is associated with LDL cholesterol specifically, but not with HDL or high-density lipoprotein or triglycerides. And it turns out that this relationship between total cholesterol and LDL weaken with age. When one looks at cholesterol levels and incident dementia, again, using this trajectory analysis, once again, we see more rapid rises in total cholesterol and then more precipitous falls in patients with dementia as compared to those who don't. And this was seen in patients with both Alzheimer's disease and those with vascular dementia. So I think one can conclude that there is a novel and unique trajectory phenotype where weight loss starts to occur 10 years before the actual diagnosis of dementia. and blood pressure starts to fall 5 years before the diagnosis. And while the results are less consistent, falls in cholesterol show a similar pattern occurring nearly 3 years before the onset of clinical depression. C-reactive protein, a biomarker of inflammation, has also been found to be associated with the future of vascular dementia in this particular study, but not with Alzheimer's disease after adjusting for common cardiovascular risk factors, stroke, and competing risks of death. It's very clear that a peripheral blood marker of inflammation may not represent inflammation in the nervous system, particularly in patients with Alzheimer's types disease as compared to those with vascular dementia. And what about diabetes? Well, at any age, diabetes is associated with cognitive dysfunction. And when you look at the cognitive trajectories, they don't rise and then fall. They actually simply decline, and they decline in a much more rapid rate in patients with diabetes as compared to those without, even after adjusting for confounding variables such as birth cohort, practice effects, sex, education, and age. There was a meta-analysis of some 19 studies showing that diabetes increases the risk of developing Alzheimer's disease and the risk of mild cognitive impairment. Therefore, Alzheimer's disease and diabetes may share common risk factors, including metabolic syndrome factors, but it's been suggested that undernutrition may be problematic in patients with dementia, or that they may develop preferences for sweet foods or snacks, which worsen insulin sensitivity and heighten a patient's risk of developing diabetes. And since both diabetes and dementia are progressive and lifelong, the prevalence of these two conditions is increasing. And healthcare providers need to develop novel ways to deliver care for patients with comorbid Alzheimer's disease and diabetes. So we've talked a lot about the cardiovascular risk factors and their relationship to cognitive decline and to overt dementia. Well, can we do anything about it? And some studies suggest we can, particularly in terms of blood pressure lowering. These are old studies, but basically the SISTER study and the PROGRESS study showed that blood pressure reduction decreased the risk of developing dementia. But this was not a universal finding. Now, be mindful of the fact that these patients varied in age, and it would appear that the SCOPE study, where they were already elderly, age 70 to 89, did not show a significant difference. And the types of medications used to treat blood pressure were also variable across the studies. Moreover, these studies had variable follow-up periods that were short, somewhere between 2 and 4 years. So, in addition to different antihypertensive drug classes such as ACE inhibitors, angiotensin II receptor blockers, diuretics, and calcium channel blockers, which may be more beneficial in reducing dementia, there are other factors as well, such as patient age, duration of follow-up, and other characteristics of the cohort. Nonetheless, those patients had marked blood pressure elevations, and many patients, as we've shown in late life, already have started to experience dramatic declines in blood pressure that is both age-related but accelerated or exaggerated in the setting of dementia. So the specific treatment plans with regard to blood pressure control and targets of blood pressure control have not been worked out for patients who are free of dementia, those with mild cognitive dysfunction, and those with overt dementia. What about diet? Well, multiple diets have been shown to improve cognitive function, and those basically include those that are glycemic poor, such as the Mediterranean diet. In this study of 334 cognitively healthy adults, median age of 67 years, they were randomized to three different types of Mediterranean diets. There was a control group. The median follow up was 4.1 years, and this study was conducted in Barcelona, Spain. And while there were no between group differences observed at baseline, the Mediterranean diet supplemented with olive oil or nuts was associated with an improved composite measure of cognitive function. And several other studies support this notion as well. And perhaps even more robust than a Mediterranean diet is that of exercise. Exercise portends not only anatomic benefits, but multiple studies have shown that regular exercise, such as walking, can markedly enhance cognitive function and retard cognitive impairment. What is the mechanism of benefit? Unclear, but multiple inflammatory, oxidative, and even stress hormone related mechanisms have been suggested. So we've been practicing for the last 20 years in the era of cardiovascular risk reduction. And many patients are indeed treated. They're treated with blood pressure lowering agents. They're treated with statin drugs. They're treated with aspirin and other medications for vascular disease, irrespective of whether they have vascular dementia or Alzheimer's disease, or the mixed type, which all account for 90% of cases. And as compared to 30 years ago, there's been a 44% lower chance of a 60-year-old developing dementia than there used to be. And moreover, the mean age at dementia onset has increased from 80 to 82 to 84, and more recently to 85 years of age. This is a slide I showed before, showing that vascular risk factors were associated with tau deposition. And that was in patients who were not treated with disease, but risk factors such as total cholesterol, LDL cholesterol, systolic and pulse pressure, and the Framingham risk score for cardiovascular disease was associated with tau in patients who were not treated with cardiovascular risk-reducing medications, but these associations were blunted and not significant in those who were treated with meds. So, a bit of optimism. So, how can we summarize the treatment of such patients? And the answer is exercise and a Mediterranean diet, hopefully for all, as hard as that is. And I recognize that regular aerobic exercise and a judicious diet may be difficult in late life. Aggressive treatment of blood pressure and obesity and hyperlipidemia, particularly in midlife, but we shouldn't overtreat in late life. And the data is showing lower blood pressures and lower body mass index and lower cholesterol levels associated with dementia in late life would urge us to proceed with a word of caution. In Alzheimer's disease, donepezil shows mild benefit, slows the progression, and, as I mentioned before, less tight blood pressure control might be better in these patients. With regard to vascular disease, risk factor modification is more straightforward. We're not only doing it to prevent the progression of dementia, but also to reduce cardiovascular and cerebrovascular events. And acetylcholinesterase inhibitors may have mild to moderate benefit, but in patients with vascular disease, patients are more likely to experience side effects and are more likely to discontinue the drug. There may be a role for antiplatelet agents and anticoagulation in patients with vascular dementia, particularly in those with atrial fibrillation and possibly congestive heart failure, and even a role for antidepressants which patients with cardiovascular disease often take because somewhere between 30 to 50% have overt symptoms of depression as well. In summary, cardiovascular risk factors contribute to the development and progression of most forms of dementia, irrespective of whether primarily neurodegenerative or vascular. Converging evidence that the pathophysiologic processes of Alzheimer's disease begins years and perhaps even more than a decade prior to the diagnosis of dementia, so that there is a long preclinical window of opportunity of Alzheimer's disease. And this is a wonderful opportunity for potential intervention with disease-modifying therapy. Cardiovascular risk factors such as hypertension and obesity during midlife are most predictive, as there are differential changes during the prodromal phase. And with regard to blood pressure elevation, patients with dementia have more rapid rises, but more rapid declines during symptomatic dementia. Moreover, there appears to be a unique trajectory phenotype that precedes cognitive impairment, characterized by more rapid falls in blood pressure, more rapid falls in weight loss, and more rapid falls in cholesterol. And some literature suggests that there's also worsening of glycemic control. Tighter blood pressure control during midlife carries the potential to prevent or delay dementia, whereas less aggressive blood pressure control and lowering therapy might be indicated in latter stages. Concerns regarding dementia could be a motivating factor in helping patients to engage in healthy behaviors and cardiovascular risk reduction. As multiple studies have shown, dementia is a primary concern of patients, in many studies even more so than death itself. Also, dementia may negatively impact adherence to other medications, and therefore I would contend that dementia is a cardiovascular, or what I like to call a vasculocardiac disorder. Why vasculocardiac? Well, most cardiac disease has a vascular component. And in fact, it's pretty hard to find a form of heart disease that does not have abnormal vasculature, suggesting that cardiovascular could be renamed vasculocardiac. Getting back to our patient, she had elevated LDL levels. That may be an opportunity. Her blood pressure seemed to be at target, so I would not lower her blood pressure further. In fact, one could make the argument to let up a little bit on her blood pressure medications and let her blood pressure rise to the higher limits of normal as well. So I hope over the last 40 minutes or so that I've convinced the group that dementia is indeed a vascular disorder, irrespective of the cause. Thank you.